And the next topic is, do all patients with HLA-B27 associated uveitis require immunomodulation? And talking on this is Dr. Parthapratim, who's again a senior consultant in the Department of Uvea and Intraocular Inflammation from Shankar Nethralaya. And countering him is Dr. Bal Murugan, who is the Chief of Uvea Services from Arvind Eye Care Systems based at Pondicherry. So let's hear from both of them.
Good evening, everyone. I hope my slides are visible and you can hear me.
Yes.
So first of all, I would like to thank Dr. Chitra and the team ARC for having me here and giving me this opportunity. And I am also thankful for giving me this very interesting topic to debate, the HLA-associated, HLA-B27 associated uveitis. Now, why it is special? Because it involves the young population. So you need to be very careful, very vigilant while treating this population. And the second one is, it is the most common identifiable cause of uveitis even in world or in India also. So if we see the epidemiology, we can see that the HLA-B associated uveitis accounted for 7 to 23% of total anterior uveitis cases in various tertiary institutes. So I'll be debating on do patients with HLA-B27 associated uveitis require immunomodulation? I'll be speaking on behalf of the motion. So imagine a case scenario, Mr. X, who is down with fever, with loose motion, stomach pain, and headache for last 4 days. Now, how his clinician or doctor, physician is treating him? Is treating with paracetamol. Every time there is a fever, he is taking paracetamol. There no laboratory investigation was advised and no antimicrobial therapy was prescribed to him. So the case was managed only with paracetamol. So you will be surprised that what kind of treatment is this? So the same case scenario went from fever, it goes to the fever of the eye. So why to treat the recurrent attacks of acute anterior uveitis with only topical steroid, which is just like a paracetamol in a case of fever, and there is no immunomodulation, there is no laboratory investigation. So this is, you are sure that this is not the right way to treat the fever of the eye. So now, before we go into the topic, let's identify two things. Number one, identify the clinical phenotype of what we call HLA-B27 associated uveitis. So as I said earlier, it affects the young individuals. It is recurrent attacks. It's characterized by a full remission between the attacks. It is unilateral, or most commonly it keeps alternating between the eyes. From one eye, it goes to the another eye. And the acute pattern is recognized by a triad of pain, redness, and photophobia. And usually there will be high fibrin contents in the anterior chamber, and hypopyon can be seen in 12 to 15% of the cases. Now coming to HLA-B27, no, we don't read the laboratory test. We always try to recognize the clinical phenotype and treat this particular clinical phenotype. Anyway, if you read this literature, HLA typing in uveitis use and misuse, it has been said that a patient with recurrent, acute, unilateral, and alternating anterior uveitis is nearly 80% likely to be HLA-B27 positive. But don't get upset if your HLA-B27 is negative, because these biomarkers can be positive in later part of the disease also. Number two, you have to understand that the immunomodulation is not a rocket science. Any drug that alters the immune response is altered to a desired level is called immunosuppression, and various agents has been included in this, starting from salazine, corticosteroid, methotrexate, and TNF-alpha blocker. But for the postgraduates and the ophthalmologists, you have to remember that the immunomodulation is required in selected cases, which should be based on the recurrence, the steroid response, and the systemic comorbidities, particularly when decided by a rheumatologist. Now, 2003 years back, the father of the medicine told that the medicine is of all the arts the most noble, but owing to the ignorance of those who practice it and of those who inconsiderately form a judgment of them, it is present behind all the arts. So true his quote is. So you have to understand ignorance is not a bliss. At least in medicine or in uveitis, there is no place of ignorance. So you have to remember, when you are treating a case of recurrent attack of inflammation, what is happening? There is collateral damage to the tissues, and which again lead to you are treating it with multiple times topical steroid. If the patient is steroid responder, then again it is leading to the cataract and glaucoma formation. Whenever there is a fibrinous content in the anterior chamber, it is going to form the synechia, and there will be impairment of the normal nutrition. So there will be formation of the cataract, there will be clogging of the trabecular meshwork, outflow, and there will be formation of cataract and glaucoma. So all these complications you can prevent if you can stop the recurrent attack of inflammation, and for that you need immunomodulation. And also you have to understand that there are certain manifestations which are rare, but it can occur in HLA-B27 associated uveitis. So some of these are like, it can present with the panuveitis and mimic the endophthalmitis. So you should not treat them with thinking them as an endophthalmitis, and it can lead to hypotony, serous retinal detachment. There are also manifestations like hypotenuse maculopathy, and then vitreous hemorrhage with repeated HLA-B27 associated uveitis and vasculitis. So one should be careful and treat all these with immunomodulation only. So here is a case I'll show you. A 25-year-old young man presented to our OPD with PLPR inaccurate vision. He was diagnosed HLA-B27 uveitis, developed secondary glaucoma. Unfortunately, he did not go to the doctor, started using the topical steroid because he was getting the momentary relief with the topical steroid. And see, 2 years later, he presented to our clinic with the intercalary staphyloma. So this was the picture when he presented to our clinic. Imagine a 25-year-old man. And he was carrying a CD with him. So when I inserted the CD, it showed me a photograph of 2 years back. Just here you see the photograph of this patient, this young man. So we could have saved this patient's vision if we had have started the patient on immunomodulation and not started him on topical steroid. So you have to understand that the immunomodulation reduces the recurrence and minimizes the risk of complication. Recently, a paper published in PLOS One, they have showed that the first-line sulfasalazine reduces the uveitis relapses, and the use of anti-TNF alpha for the ophthalmic purpose was unnecessary with rare exception. So you have to decide about this rare exception and plan this treatment with when you are deciding for the biological. But immunomodulation in all cases, when there is a recurrence attack of uveitis, is must. So our mission to preserve the vision is, when our mission is preservation of vision, then we have to remember that it is dependent on the remission. So other than immunomodulation, nothing else can help us to achieve this mission. So in a study, it has been seen that the 73% reduction in the inflammation was achieved with the oral methotrexate. So immunomodulation is the answer when we are targeting the remission. So next important point is you have to think beyond the eye. You have to understand that you have to, you can diagnose systemic disease that may have permanent and debilitating effects like bamboo spine, ankylosing spondylitis. So it has been seen that among the patients of HLA-B27 associated uveitis, 2/3 to 3/4 of these patients will have associated spondyloarthropathy. And in another important study, it has been seen that the 78% of the HLA-B27 associated uveitis was associated with extraocular disorder, and 65% was diagnosed only as a result of ophthalmic consultation. So being an ophthalmologist, there is a huge role to play here. You can actually diagnose them and send them to a rheumatologist and start the immunomodulation and prevent all this kind of permanent debilitating effects or systemic manifestation of this disease. So to all the postgraduate, you must read this DUET, which is known as Dublin Uveitis evaluation tool, which has recognized, developed, and validated the assessment algorithm for the spondyloarthropathies and HLA-B27 uveitis. So this is, they also found that the 40% of the patients enrolled in their study with acute anterior uveitis had undiagnosed spondyloarthropathy. So just to, I'll finish with this DUET algorithm. What it says if you are seeing a case of acute anterior uveitis, you take the history of spondyloarthropathy. There is history of spondyloarthropathy, no further workup, treat the uveitis related to spondyloarthropathy with immunomodulation. If it is no, take the history of backache. If the age of onset is less than 45 years, duration is more than 3 months, and joint pain which require to take analgesic or general practitioner, visit to a general practitioner. If the history is positive, then you have to check HLA-B27 positive. If the HLA-B27 is positive, then you have to start the immunomodulation. And if it is negative, you have to take the history that whether there is any known case of psoriasis or any past medical history. If that is also not there, then you have to give the patient a handout. This handout should carry the information that in future he can develop HLA-B27 positivity and require immunomodulation. And if there is no history of backache and no joint pain, then you can give him the same handout and send back with topical therapy. So yes, you look at this 4 picture, we can prevent these clinical conditions. Only we need is right amount of immunomodulation at right time. Thank you.
Thank you very much, Dr.